point, maybe we can have all the panelists turn their videos on, that we can go into a general discussion. So if any participants have any questions for the overall panel or targeted, we can certainly kind of get to all those. And maybe we could start with, I think, some of the ones that we weren't able to answer initially. So I'm going to figure it out based on timing what these questions are from. But there's a question from Shahira Hanif. I think this is from the very first presentation with from Lynn. So Lynn, did the researchers, did you as researchers notice any ethnic variations in your attitudes with regard to disgust?
That's a wonderful question, and we didn't, because our sample was this convenient sample from MTurk, and we didn't power our sample to have enough ethnic variation. But I think that's definitely something that moving forward we should look into, because we know that you know, especially around things like disgust, propensity, and sensitivity, there are definitely some cultural implications. So yeah, absolutely, great question.
I'm just going to take another question, some leftovers. This one I think is for Rob, from Isabel. Question about fees being the main barriers in the US. I think there's a couple of questions in the chat on that. How did you capture that? Obviously, there are some structural barriers to colonoscopy. And again, this is maybe open to all of the panelists, because there's international variation here. So the questions of fees in colonoscopy obviously doesn't necessarily exist in some programs, but does in others. So Rob, did it come up a lot in your review?
Yeah, it did, especially in the American studies. So unfortunately, I didn't have time to kind of go through all of the barriers and facilitators we identified. There was over 30 in total, but 2 of them did kind of very much relate to the financial implications of colonoscopy in the US. So one was around the actual cost of the colonoscopy. So if it is covered by your healthcare insurance, I think you would still have to pay like a cost toward it. And then the other was actually being available on your healthcare insurance kind of period. So for some people, their healthcare insurance didn't include colonoscopy as a screening modality, but perhaps other screening modalities were available to them. So maybe they could opt in for FIT. And then where it was available, there was still a cost incurred. And there was some really kind of interesting quotes around that. So one person saying, for example, that they would have to essentially make a choice between having a colonoscopy and buying groceries that week, because the cost was so large that, you know, their financial circumstances didn't really allow for them to pursue it. And that came up a lot, people saying that they wanted to have colonoscopy, but they just couldn't afford it. And kind of also on that note, like in the US, many people stated that they wanted colonoscopy because they saw it as being the best test. They have a choice of tests, so they can have FIT or they can have CT colonography, but they often wanted the colonoscopy because it was considered the best test, but they just couldn't afford it.
So we have a question. I believe this is for Lucinda. You know, from Leo Van Rossum. If people will not adhere to colonoscopy, why do they do the FIT? Did you ask them that question?
Yeah, we did during the interviews, and what we found was that people just cooperate without thinking, really. So we generally found that people just do it because they get the invite and don't really consider what the potential consequences might be of having a positive FIT. So they just don't really think about it, and don't. I think this also points towards the fact that participants may not read the information that they receive, like with the invite. very thoroughly. So yeah, they just participate because they can, really. Yeah.
And I think here's another question for Lucinda. Did you adjust your findings by gender and age? And also maybe opening to the whole panel, what are your thoughts on individual differences? We touched on ethnicity, but also gender and age differences.
Yeah, we did adjust for all the demographic variables that we measured. So gender, age, education level, income as well. But those did not appear to be the major factors that were associated with non-uptake of colonoscopy, in our sample at least.
It's interesting, this point sometimes of people doing the test without thinking. Because I've had many people, when they hear about this problem, they say, oh, like people should have to sign a consent or something like that before they do a fit, saying they'll do the colonoscopy. But it seems like you would, you might discourage a lot of people to try to capture these few people who would do the. So it's an interesting sort of like pragmatic trade-off of how much do you kind of hit people over the head with the fact that you have to do a colonoscopy if you're going to do before you do a fit.
Yeah. Yeah. Right.
So
yeah.
That's
definitely. And
interesting.
I mean, most people do undergo the colonoscopy, and they don't have any difficulties with it. So it's a small amount of individuals, and also, yeah, they are free to make their own choice. I mean, shouldn't push them too much, I think, because some people have genuine concerns, and just some individuals do not want to know if they have colorectal cancer or not. So yeah, that's their right, I think. So yeah, I definitely see your point. We need to find a balance, I think, between informing people as well as we can, without pushing them too far, and without maybe scaring other people away by making it a little too focused on the goal of increasing colonoscopy participation. Yeah, good point.
I think it's also sometimes different what people say they will or will not do before the test, hypothetically, versus after they have a test. So
yeah, I think that's definitely true. I mean, and also, I mean, the circumstances sometimes change. I mean, sometimes other stuff comes up, and they realize, oh, maybe it's not a good time for me right now to do a colonoscopy because my mother is dying, or so I think that those are valid concerns that we should take into account, while maybe simultaneously offering the opportunity to do it at a later stage, or yeah.
Another question, maybe again, this one perhaps for Andrew, I think it might be interesting for you. To what extent is virtual consulting an option, especially right now? I mean, you've talked about all the mitigations that you had to undergo. So virtual consultation, is this something that could help, especially with also more rural areas in mind?
I mean, absolutely. I mean, we found that there's been a drop in attendance at the clinical assessment, because we are now doing a lot of these by virtually. So, people are not having come to the hospital. They can have their assessment done virtually. And so we've seen that DNA to clinical assessment drop during the pandemic. But I mean, I'd like to ask, if I may, I've got a question that I think I'd like to throw open to anybody, and particularly in Linda, in terms of your presentation when you were talking about effect and decision-making processes. And, has the pandemic made people more health aware? In terms of, okay, we may have vaccines that work, but actually, the general population around the world, and I'm talking with my health promotion head on here, had to look and become more health aware about not becoming ill, the procedures that they have to put in place to make sure that they look after themselves. And, you know, if the vaccines are to work, great. But can we harness this? You know, has there been a shift, or will there be a shift in how people consider their health? And, you know, trying to think on the positive side, out of the negative of the pandemic, are people more aware of their health? And, you know, as people as health professionals, you know, we've always had this sort of drive that looking after yourself is a positive thing. But Linda, in terms of people's, you know, in terms of effect and decision making, do you think this could be an outcome?
Well, I guess I'm not 100% sure about how it will affect colonoscopy, but sadly, I think that the stress and fear people feel about COVID-19 is limited to the disease. Like, I'm in the middle of doing a study with parents about vaccine decision making, about HPV vaccine decision making, to see if some of this work, some of COVID will impact that work. And we are finding that that people still have vaccine hesitancy, and they have COVID-19 vaccine hesitancy, and also HPV vaccine hesitancy. It hasn't changed it. So while I know that that's primary prevention.
They may have vaccine, but are people more, do you think in terms of the work that you've done, that people are more health aware?
It's a great question. I'm really not sure, but no, I think, and this is really anecdotal, but I think that people are more health aware about germs, infectious disease, and definitely about COVID. And I think people are putting like other preventive behaviors behind. And I even think about, for myself, for my children, like I skipped their dentist appointment in April, and I'm a health outcomes researcher, and I still haven't taken them just because I've had other triaging other priorities in life, and I hold their health to be paramount. So sadly, I would suspect that it hasn't made people more, it's made them more health aware. It's siloed.
Being too optimistic there.
Yeah, well, but I would be curious to what others think about this.
Yeah, I think there could almost be an opposite effect too. I think there's also a bit of a health fatigue, sort of so it's interesting. I mean, I'm not usually an infectious disease researcher at all, but I've done some sort of work on COVID the last 4 to 5 months, and there's kind of this gratifying thing that so many people are focused on health right now, and health research and health and what's going on. But I'm a little bit. I join Lynn more in being a bit skeptical that this will trade off, that this will slide into preventive health, and wanting to think more about colorectal cancer prevention afterwards.
Sure. I am being too optimistic then, obviously.
Hopefully not.
We'll see.
We've got another question here from Leo van Rossum about compliance and whether it declines with the time after a positive fit. I don't know, Kevin, you sort of provided some estimates about So
the question is, does compliance decrease? So you're saying that
So perhaps
I'm not sure if I
within
understand.
the first X amount of months it doesn't get done, is it less likely to get done over time?
Yes, I think that definitely there's kind of a curve where you see in almost every program, most of the colonoscopies get done in the first 3 months or so, and which is sort of a realistic amount of time for everybody to get organized, do your prep, get time off work, and everything like that. And then there's a bit of a lag till 6 months. And then in the programs, the curves I've seen, relatively few get done between 6 months and 12 months. And then you kind of plateau at that point.
Yeah, I would just comment too. I think, a lot of the studies, some of which Kevin has cited, they do look at follow-up colonoscopy up to like a year or maybe even longer. But I think you have to question if people are getting a follow-up colonoscopy a year after a positive fit. Is it really because of the positive fit, or are they actually developing symptoms or something else, right? Because generally we're not getting follow-up tests a year after they happen. So I think something to consider when we are reading kind of those studies. We have another question from Lucy Peck to all the presenters, really about, I think, information sharing with the patients. Do you consider easy read information when sending letters or questionnaires to people? So I think taking into account maybe grade level and things like that.
Yeah, we did have someone check our questionnaire on readability, and I also did cognitive interviews with people. So that's when you sit down with someone and you have them go through the questionnaire and see if they can understand all the questions without you having to provide extra information. So we do take that into account, but I think that's true for most people who design questionnaires.
I have another question here from Evelyn Decker that I think is quite interesting and something to discuss for the whole panel. And that's about privacy and the ability and how that relates or impedes the ability to get high quality data on this issue. As I said, I really like the presentations, and you all managed to get really great data, but there are some issues around privacy legislation in this type of study. So I don't know, again, from an international perspective, what have people's experiences been in conducting these studies?
Andrew, I think you're muted.
From our perspective, at a screening center level, we are not allowed to contact people that don't respond. If they've had contact with the screening center, we can have an intervention. But if there's been no contact, then we are not allowed to contact those people.
I'll just pipe in. This is somewhat tangentially related to Evelyn's question, but in the study that Kevin presented, one of the things that we want to do, because we are interested in health inequities, was to see if there are any disparities in terms of race, ethnicity, socioeconomic status. But we found that one, such information is often not recorded, and two, that some programs are expressly prohibited from collecting that type of information. So which I think is, which kind of opened my eyes about what is allowable in different programs and regions of the world.
To follow that, in much of our work with African Americans, we have found that people don't like to answer some of those questions about education, but definitely about income. And we've had to do like some kind of like fancy imputation analyses for most of the work that we do to sort of estimate it, but it's not using those kind of models. It gets close, but it's not the real thing. So we don't have a lot of that information to be able to understand some of the inequities as well.
I have another, just going back a little bit, I have another question for Rob. This is a question about, from your review, which of the barriers that you found surprised you most? Were there any sort of surprises? This, again, sort of a question from a little bit early on that we didn't tackle. But yeah, which one do you think was the most surprising factor, and also maybe which one do you think is the most important one after having done this review?
It's a really difficult question to answer. I think in terms of most important, it really, I think, varies from one context to another. So I think, with the States, it sounds like the financial barrier is perhaps the biggest one, but then it doesn't apply in many other settings, and perhaps fear of pain might be the most important one kind of overall, I think, especially because sort of since conducting the review, I've been interviewing specialist screening practitioners who they conducted the pre-colonoscopy assessment with any patients that have an abnormal FIT result. And after speaking to them, I mean, I asked them in the interview, what's the, you know, what are some of the frequently asked questions that they get by patients? And they've all responded to say, you know, will the procedure be painful? So I think that's kind of at the forefront of everyone's mind when they're being invited for colonoscopies. Is this going to hurt? So yeah, perhaps that's the most important barrier, I think, for a lot of people. They're really worried about that procedural pain. I think it's kind of also reflected in Andrew's data that, you know, people are much less anxious after they've had their colonoscopy, because I think so much of the anxiety is caused by, well, will the procedure be painful? Then in terms of most interesting, I think just one thing that really interested me was that in the literature generally, there's so few studies, qualitative studies that have been conducted outside of screening colonoscopy. So for like diagnostic colonoscopy or surveillance colonoscopy, I only found 2 papers that looked at surveillance colonoscopy, for example, like why people don't attend surveillance colonoscopy, and 2 papers why people don't attend after an abnormal FIT, although Lucinda's just published one as well, so 3 papers now. But yeah, I think that was quite surprising to me that there's been really just so few qualitative studies on that front.
So there's a question from David Armstrong. You know, do you or anyone think that people feel that a FIT is likely to be negative? Because as we know, 93% of time is usually negative, and therefore they expect to be reassured. Whereas a colonoscopy, they're more likely to find abnormal findings such as a polyp, even if low risk implies a greater risk. Maybe I could ask Jane first, because obviously you mentioned that in Scotland the threshold for positive tests is 80, which is higher threshold than in a lot of other places. So do you feel that for your participants or in population, they are much more kind of nervous or struck if there is a positive or abnormal FIT test?
I would say that's one of the reasons for doing this study in Scotland, to provide people more information, because we use such a high cutoff, that people might, that they could be sort of 70 to 80 and not then just be told that they're negative and not realise that they are at much higher risk, and that in other countries they would be invited for colonoscopy. But at the same time, I don't think people in Scotland are really aware of that or know what the cutoff is. But I do agree with the comment that I think people assume that they want the reassurance that they'll be negative, and maybe that's why they're taking part. And when they if they are positive, then that wasn't what they were expecting, and then they have to consider whether to go for a colonoscopy or not.
I have a question for Lynn. When you gave your talk, I thought a little bit about fear, and I think Rob brought it up and others brought it up, that obviously is another barrier. How do you feel it relates to the disgust and other sort of effective barriers? And it's quite multifaceted, because you can be fearful of the procedure and you can be fearful of the outcomes. So just wondered what your thoughts are on fear.
Yeah, thank you. I think that disgust just tells like one piece of the story, and these negative affective states are really important, especially the combination of disgust, fear, and embarrassment. I know Lisa Reynolds and Nathan Considine in New Zealand have done a lot of work looking at colonoscopy avoidance with fear, disgust, and embarrassment all together. And I think they're complex emotions that interact with each other. So I think, when we think about messaging for colonoscopy, especially if it's written, if it's not something that you have a face-to-face with a physician or a nurse practitioner, I think it's really important to consider all of those different worries, fear, embarrassment, and disgust together.
We had a question from Manuel Zorzi. I believe this is for Lucinda. In the Dutch program, is colonoscopy for FIT positives free of charge?
Yeah, it's a little bit of a complicated situation because in the Dutch healthcare system, we have an insurance system, but you have your own deductible. So that's a certain amount that you have to pay out of pocket. But once that amount, once you have reached that amount, then everything above it is free of charge. So we found during the interviews, out of the 23 people that we interviewed that did not do the colonoscopy, that only 2 people mentioned the having to pay for colonoscopy or for like a certain part of the colonoscopy, not the entire fee, but it's probably a few €100. That was for them a barrier, but most people were unaware of the fact that they had to pay for it, mostly because at their age, some of them already were on medications, which means that they were already using up their own deductible throughout the year, or they just didn't think that was that much of a barrier for the colonoscopy. The 2 individuals that did mention it, they had raised their own deductible to a maximum amount far above the amount that was normal for most people. So they were having an issue with it. And one of them actually waited for a year and had the colonoscopy the next year when he lowered his deductible to a more reasonable amount that he had to pay out of pocket. So it's not free of charge. It's also not that expensive. And we did ask in the questionnaire a question on income. We asked to what extent people experienced financial difficulties. So this was not a question on income, but we couldn't really ask a question about income due to privacy legislation. So we asked about experiencing financial difficulties. And this was not a factor in non-uptake of colonoscopy, at least not in the Netherlands.
And Kevin, you also showed in your study that in terms of what was the cost for the different for FIT positive for colonoscopies. Do you mind just summarizing it again? What you found?
Yeah, so that was that in over half of programs, colonoscopy after a positive FIT was completely free, and then after that, the cost was. In Switzerland, we actually have a similar thing to Netherlands, where there's this copay up to a certain amount each year, and that you can almost never get rid of it. And so similarly in Switzerland, you can end up paying up to about $150 to $200 for your colonoscopy. That depends on how much you've already paid this year, in the same year. Yes. So, and that's about the upper limit of how much people said that FIT, the colonoscopy after positive FIT cost in their program.
Thank you. And I think this is our very last question in the Q&A from Isabel Portillo. And I believe this was for Rob's presentation. In terms of the practical barriers that you found in your systematic review, are in the US, are fees the main barrier?
Yeah, I think that came up. I may have touched on it already briefly. Quite often in the studies in the USA, that participants wanted to have the colonoscopy but could not afford it. Certainly, that was the case with studies that looked at more, say, deprived groups, or even some studies with ethnic minority groups as well found that they often wanted the test but couldn't afford it, or they didn't have it wasn't covered by their health insurance, so they would be eligible for other screening, which they also would have to make a kind of contribution toward, but it wasn't often available to them. So I think, yeah, that the cost aspect is really important for in the USA.
Great. Thank you so much. Well, we've managed to answer all of the Q&As from our, and I think the hour is late. So I think we do have some, I think maybe last slide as thank yous, but I just wanted to first of all, thank all of our panelists, Kevin, Rob, Lynn, Lucinda, Jane, Andrew, and my co-moderator, Christian, for for being here, and of course to our participants from really all over the world for attending. This wouldn't be of any interest if it's just the 6 or 8 of us sitting around talking. So things just to note that presentation slides will be made available on the WEO website next week. And I want to thank so much to the WEO Secretariat, Alexandra Uninger, as well as Ruth Bucksh, without whom this could not have been possible at all. I just want to note that of all the expert working groups, we were told that we were the only expert working group who were able to actually have a separate meeting aside from the main WEO screening meeting. So I think that really tells us how, I think excited we are, passionate about about this topic. So thank you all. And a big thank you again to our sponsors listed here. So with that, I want to again thank you everyone for participating and wish you a good afternoon, night, and a good weekend wherever you are. Until next time, thank you.